Hello, Dr. Childress. This is my Vitae Series. Welcome. So we're up to the point of my leaving the Chalk UCI collaboration and moving out into my other projects. Now, during Chalk, my Chalk period, a project came along through the Orange County Fire Authority and Department of Justice and FEMA. And what they wanted to do was develop a model for the mental health assessment of juvenile fire setting behavior. Now, I don't know anything about juvenile fire setting behavior. I'm an ADHD guy, early childhood. But coincidentally enough, we have in Southern California the world's foremost authority on juvenile fire setting behavior, Ken Feynman. He's a forensic psychologist. He wrote the book. He is the world's foremost authority on juvenile fire setting behavior. And so he had the content knowledge. I'm a clinical psychologist. I know how to put together assessments and assessment protocols. I've worked at UCLA. I've done all sorts of assessments. I was trained at Pepperdine in how to put together assessment protocols. I know how to do assessment protocols. So I was brought on board as the clinical psychologist to bring that project together, to create the assessment protocol. Dr. Feynman came and brought the content knowledge. And then we worked with Kathleen out of the Orange County Fire Authority on the firefighter knowledge of juvenile fire setting behavior. And because juvenile fire setting behavior is a court-involved behavior, it's in the domain of forensic psychology. So that was my first introduction to forensic psychology. Dr. Feynman, developing a good friend, good collaboration. And he's a forensic psychologist, and so he kind of orienting me to the world of forensic psychology. And I, that's when I looked at read the standards, APA, AFCC, all these standards for being a forensic psychologist, because we have to meet those standards as part of our assessment protocol. So we set about sort of systematically developing the assessment protocol. First thing we had to do was triage. So we're taking responsibility. We're going to do this triage. If a kid sets a juvenile fire somewhere, they're going to get referred to us. We need to kind of triage what's the level of concern. And the issue that FEMA and the Department of Justice want is a mental health assessment of the kid. Well, some fire setting is just curiosity. You got a 7-year-old playing with matches, and they didn't mean to set a fire. They're just playing with matches. It's just curiosity. It's as simple as that. And so it's no big deal. So that's the first category. The second category is there might be some emotional, psychological, family issues kind of going on that would benefit from a mental health assessment to understand more about it. The issue also in the forensic side is this fire setting behavior has become court involved. There's criminal. And so the question is this kid more on the juvenile justice side? Should the court be sending him to juvenile hall? Or is this kid more on the therapy, family problems side that we should be getting therapy for the kid? And so it's a differential of, juvenile hall or psychotherapy. And so that's the central component of the protocol we're assessing. Those kids, we call them complex. So they're simple, complex. And then the third category is kids who are frightening in their fire setting behavior. These could be like the real severe juvenile justice kind of kids that are using a fire for purposes, vandalism, arson, kind of things, or injury to people. And then the other category of the really serious, concerning one is kids with autism spectrum who get obsessed with fire. And they don't have the cognitive abilities to recognize you shouldn't be doing that. And so those were also the concern. We call that third category emergent. So we needed an instrument that would triage into those three categories. The simple ones would go off to the fire agency and get training in fire education stuff. That was enough for them. They have all-day Saturday training by the fire agency. The complex ones, the ones in the middle, would come in for a more comprehensive mental health assessment, which we developed. And then the emergent ones, high-risk ones would get immediate into psych hospitalization or the juvenile justice system. And so we had to triage that. Now, when we're triaging that, we're developing an assessment measure for triage of a very dangerous behavior. People don't want juvenile fire setters in their residential treatment center or setting, psych hospital, whatever. They don't want people in those settings because that's a high-risk behavior, and they become liable if one of their patients sets a fire that hurts other people. The treatment center, the residential treatment center, will become liable, or is afraid they'll become liable for the damage caused because they accepted a kid with juvenile fire setting symptoms. So our assessment protocol, part of that was also designed for helping treatment centers realize what's the issue, motivation with the issue, and is that a risk behavior? Well, if we're doing that triage and we're doing a risk assessment, we kind of become liable. If we say the kid is a simple curiosity fire setter and it turns out they set more fires and they're not, and somebody gets down, well, are we liable because we said they were low risk and they're actually high risk? Yeah. So it became very important to understand, to do a good job of that risk triage assessment. So I did a lot of research into risk management kinds of assessment protocols and how to do that. We're really not very good in clinical psychology on doing risk assessment. I mean, there's no information, there's problems with it. We over-identify, that's the issue. We can identify the factors of concern. The problem is out of 10 kids that we say are at risk, only one's going to do it. The other 9 are what's called false positives. We say they're at risk, but they're not going to actually do anything. So if we wind up providing treatment, we wind up providing treatment to 10 kids, 9 of whom don't need it. And that's a tremendous waste of financial human resources in psychology, treating 9 kids who don't need it to find the one kid who does. So the risk management assessment is to narrow that down from 10 kids who are at risk to maybe 3 kids. Now, of those 3, we can maybe treat all 3 and catch that one. But, so that's the goal of, and we're not very good at it. There's no way to identify who that 3 is out of the 10, or who that 1 is out of the 10. There's just no information on that. And so we looked at that. But we did, I think, my structure, I think I did a good job on the screening measure. It's just the whole domain of different types of behaviors, and it has to sample the entire domain. So I did the various procedures about sampling an entire domain. I generated the list. I took them to Ken Feynman. I took them to the firefighter. I spread them around, and we got input about, is this all the different types of fire setting motivations, behavior. And then we categorize them into simple, complex, and emergent. What type of fire setting behaviors are indicators of curiosity? What are areas of potentially more concern, and what are the serious ones? And so then we developed criteria for simple, complex, and emergent. It had to be an instrument to be delivered by the firefighter in the field to the kid as an initial triage. Then those kids that were identified as complex would then come in, and we had a mental health assessment. Dr. Feynman and I developed his content, my structure to it, for a more elaborate assessment. Now, both the screening instrument and the larger assessment protocol, at least for the child, we had one for the child and one for the parent, are up on my website. So you can go up and look at those and see those assessment protocols that I developed. And in those, you will hear echoes of the assessment protocol for ABPA, because it's essentially the same thing. It's developing an assessment protocol based on the constructs of assessment. How do you develop that? That's what clinical psychologists do. Psychiatrists go medication, MFTs do therapy. Clinical psychologists are trained in specialty practice in assessment. We're the ones who construct the intelligence tests, the personality tests, any test of psychological issues is developed by clinical psychologists. We're the ones who do that. And so that's my training background is developing test assessments, developing, administering, scoring, interpreting, all the aspects of assessment. That's what I do. That's what I'm trained in. That's my specialty, clinical psychology. Cited, I do therapy, I do assessment. I know how to do this. So with juvenile fire setting behavior, I'm applying those principles to fire setting. Ken Feynman has the knowledge of fire setting, but it's the principles I'm bringing. With attachment-related pathology in surrounding divorce, in high conflict divorce, that's the content area, is attachment pathology surrounding divorce. But I'm just bringing the principle of pathology assessment and applying it and developing an assessment protocol for that particular type of pathology. So it's the same process with the juvenile fire setting behavior and with the attachment-related behavior. It's simply a different widget, a different type of pathology. And so the variance in the two assessment protocol just simply reflect the variance of the two pathologies and the referral question and what the question is. Now, interestingly, both the juvenile fire setting behavior and the attachment-related pathology are court-involved. And so they're both in the domain of forensic and have requirements layered on about the court for evidence and decision-making and information. And so I have background in developing an assessment protocol for court-involved pathology with juvenile fire setting behavior that then I bring to the development of an assessment protocol for attachment-related pathology that's court-involved. Same process, different widget. So that was my juvenile fire setting component of that program. It started when I was down with OC, Children's Hospital of Orange County, and continued for about a year or so into my work as a clinical director at Children's Assessment and Treatment Center.